This is Janice Lopez from the International Organization for Migration, and welcome to the Migration Health Research Podcast. We are happy to present to you the 33rd and final issue of the Migration Health Research Bulletin, featuring publications on assessment reports on POEs or points of entry, research report on HIV, study on kidney health risk, manual on psychosocial interventions, and primer on migration health data. For a podcast episode, we discuss with Tamsin Fernandez-Cox, Regional Public Health Officer in the Migration Health Unit of the IOM Regional Office for Asia and the Pacific, the challenges in POEs in responding to public health emergencies. We also had the opportunity to talk with Dr. Kol Wickramage, IOM's Global Migration Health Research and Epidemiology Coordinator, about the strategies for improving migration health data at the country level. Let's listen to Tamsin.
As we saw during COVID-19, at a global scale, airports and seaports, of course land border crossings as well, can act as critical gateways for the detection, containment and also response to potential health threats crossing international borders. So ultimately, the aim of these assessments in particular and the consequent reports that were produced was to conduct an in-depth analysis of POE overall compliance with the core capacities. I know I'm using a lot of technical jargon here, so I'll go into some of this in a second, but the core capacities required as laid out in the International Health Regulations 2005. IHR 2005, you may be aware of these already, but a very quick refresher is that the IHR 2005 is a set of rules to basically support the global outbreak alert and response system and to require countries to improve international surveillance and reporting mechanisms for public health events, as well as to actually strengthen their national surveillance and their core response capacities. This entered into force in 2007, legally binding on 194 countries across the globe, including all WHO member states, and it covers lots of technical areas, and one of these is specifically targeting POE. Whilst obviously our overall purpose was to kind of assess the core capacities I just mentioned, sometimes where we can get lost as humans is also to think rather unilaterally about these issues. We're doing a health assessment, so we should only look at, health officials. But health capacity at points of entry is not just a matter involving health authorities. It also involves immigration, customs, biosecurity, environment, private sector actors, operational actors, and so forth. So these reports really have aimed to fully integrate data and information from a really multi-sectoral point of view, featuring all of the above perspectives and more, because they were all included in the assessments. So in each country, we had all these key different actors who were specifically questioned. So ultimately, the assessments and their consequent recommendations aim to provide an enhanced understanding of the actual challenges faced at these points of entry across the board. We aimed to evaluate the functional readiness of these POEs to detect and respond to public health emergencies, both in routine scenarios and also during a fake, terrible name, but I'm sure you are familiar with it, a public health emergency of international concern, but also coming at it from the all hazards approach. In light of that, to identify the critical gaps in infrastructure, human resources, screening systems, training, referral pathways, coordination mechanisms, and yes, as I mentioned, compliance against IHR. Then, as a super actionable last step, also to provide easily digestible, actionable recommendations that are tiered for national governments to either themselves start making changes, as well as, of course, for donors and other implementing partners to support on to enhance health security. In summary, basically what that means, we got all of the stakeholders in a room together, we got all of the recommendations, and we basically got them to rank them in terms of feasibility, in terms of priority, and in terms of estimated timeline it might take to implement something like this. We then kind of grouped these from priority 1 being critical priority, highly feasible and immediately impactful, to priority 6, the least priority, least feasible, or very, very complex with a low impact. So at the end of the document, you literally have kind of this ready-made action framework to go ahead and start implementing on. And also, for anyone that doesn't fancy reading a rather long assessment and all of the consequent recommendations along with it, this rather is ranked and categorized very neatly as an annex in the report to allow for a really practical use at the national level and, of course, for any other partners too.
Do you mind sharing with us the key findings from these two reports? Any highlights that you want to emphasize at this point?
as noted, these two country-specific reports aimed to assess public health emergency preparedness and response capacities. And in terms of key findings, I think actually, whilst contexts differ a lot between Tuvalu and Vanuatu, both countries did face a lot of similar challenges at their points of entries. Some shared were overall, I did find limited properly trained personnel at the POEs. Many of the people who worked there were performing multiple roles and of course also sometimes lacking, having had the investment in proper training. And this goes across the sectors, immigration, health, etc. And this obviously includes any sort of public health emergency training, or if they had been trained, maybe it was back specific for COVID-19. Also, neither country had permanent physical presence of health actors at the POE if something were to happen. This is also linked to both of the countries having health system capacity restraints massively at the national level too. I also found there was a absence or otherwise sometimes limited use of SOPs specifically related to, for example, screening, isolation, referral, and risk communication. Typically, any SOPs that did exist were either designed again previously to be COVID specific and either hadn't been updated or adapted to be used for routine times or for other potential fakes. Obviously, there are and were some SOPs, but not every official either knew of them or had access to them. So then in line with this and reporting and documentation, I think both countries overall lack POE integration into national emergency response plans, or absence entirely was an issue. And if the country did have an emergency response plan, POEs weren't a part of it. Again, both countries, I'm referring to both seaports and the airports, had very sometimes inadequate infrastructure specifically related to medical capacity in terms of designated screening and isolation areas, medical facilities on site, communication systems. And I think there's a lot of work that needs to be done there and upgrades, ensuring that we are IHR compliant. Also, whilst efforts were made in terms of task forces, joint meetings that are kind of either ad hoc, pretty informal, don't happen all the time, I think both countries were really burdened by weak coordination across sectors with very siloed operations often between health, immigrations, customs, and obviously any of the other ministries, which we really, really need to work harder to ensure that we are doing. Also, overall, a lack of drills, simulations, and other regular assessments to test emergency readiness. Lastly, in terms of joint ones, procurement, significant problem for both countries in terms of PPE, disinfection, decontamination and disinfection materials, in terms of availability, stockpiling or rather lack thereof, and also the ease of procurement. I mean, these are remote island nations, and then also funding in relation to it. So I think lots of key gaps across both.
Could you share with us these findings, implications for policy or program, or how you envision some changes in terms of policies and programmings in POEs in Tuvalu and Vanuatu?
The findings show that whilst everyone is doing their best, we have a very long way to go at the national level in terms of national strategies alongside at the regional level and operations. So we have kind of higher level initiatives, including the Pacific Public Health Surveillance Network, or the PPHSN, the Pacific Regional Action Plan on Healthy Environments. All of these kind of bigger policy level things aim to and can, certainly support improving coordination, information sharing, and joint response mechanisms across borders. And they also recognize that many health threats in the Pacific, for example, vector-borne diseases, also climate-sensitive outbreaks, food security shocks, these things are transboundary in nature. They don't just affect the Pacific. And so we require not just even a collective regionally harmonized response, but a global one. Now, for small island states with limited health infrastructure, at least the presence of these frameworks can also kind of help support access to pooled resources, surge support and technical assistance, where obviously health risks can enter by sea or air. As I mentioned, let's stop thinking regionally and let's think more globally about global health security and all of the activities that are required, and not just reactive but proactive, to minimize the danger and impact of acute public health events that endanger people's health across the globe. In terms of infectious diseases specifically, as we know, COVID was not the first pandemic, but it was really a pandemic that affected all of us, and it will not be the last. WHO has said that we have entered the era, the age of pandemics. And pandemic preparedness is still a huge issue we need to keep working towards, even in this more funding challenged era, shall we say. At the end of the day, health doesn't care about borders. So as the assessment showed, we really do need to be investing more time, effort and resources specifically into institutional as well as infrastructure strengthening. Investment specifically in fit-for-purpose infrastructure in terms of screening, isolation, clinical evaluation at POEs, PPE, proper cargo screening facilities, equipment, and we do need to have trained and dedicated POE health personnel who are also trained to deal with, emergency response. We really need to properly formalize protocols, emergency plans, SOPs, and obviously ensure that these are aligned with IHR and tested regularly through simulation exercises, and that obviously everyone is aware of what to do, how, where, when, and why. We also really need more intersectoral coordination. So I'm saying it again, but at the very least, national POE task forces to ensure really routine collaboration between health, customs, immigration, agriculture, every sector. And then, of course, this type of collaboration and discussions also ongoing at higher levels. And that needs to be routine, not just in times of emergency. But then we can obviously, during times of emergencies, have additional response mechanisms for that as well. I think as well, a last couple would be, really integrating with broader preparedness plans. In Vanuatu, we're already using the findings to inform the implementation of the JE recommendations, and we're also discussing the findings and about to present them to a number of other key partners in the region. But we really need to ensure integration with existing plans in the country, which is sometimes lacking. And I think all of these things we need to really bring together and bring all of the key stakeholders and actors together at the table so that everyone is informed of what is actually happening and why. And in Tuvalu, I think obviously there is the issue with aligning POE development with climate adaptation planning and recognizing really the unique vulnerabilities, particularly of the smaller island states. We need to position POE capacity building in terms of infrastructure and personnel as a really priority area for international assistance that will also link to more climate resilient health systems as well. So really encouraging more donor engagement and resource mobilization, and also kind of encouraging co-funding and technical partnerships with regional and global health sectors, and, monitor these and support obviously for continuous improvement. In sum, these reports can and do actually now just offer a practical roadmap for transforming border health management in both Tuvalu and Vanuatu and soon to be Tonga, helping ensure some of the more remote entry points in the world are actually equipped to detect and respond to the next public health threat. Because again, as we know, a health threat anywhere is and can quite quickly be a health threat everywhere. Also, by grounding the assessments in the IHR, which ultimately, also seeks to encourage the continuation of travel and trade, we hope these reports just serve as a diagnostic tool to inform strategic investments and planning at, of course, national and regional levels with global implications.
Now, let's listen to Dr. Kol.
The primer on migration health data really arose from this dire need for technical guidance at the global level in order to support governments, organizations, entities to advance migration health data. And the reality is that disaggregation of health data, be it, infectious disease outcomes, social determinants of health data, health equity data by migratory status is very poor. And as a result of the lack of integration of migration modules within routine health information systems or migration governance systems, the data and the science of health of migrants are quite invisible, right, in routine collection systems. So we don't have, for example, readily available data disaggregated across, infectious disease, NCDs, psychosocial mental health, and of course the determinants of health. So we don't have that. And that is really problematic if you want to be targeting health interventions, formulating evidence-based policies and engineering interventions, healthcare financing, and to address global health. You're just blind, essentially, if you are a steward within a healthcare system. So I think one of the clarion calls of many international frameworks, be it the Global Compact of Migrants and the World Health Assembly resolutions, global consultations in migration health has been the need to better collect migration health data for evidence-based policy making and programmatic formulation. Yet we don't see that. And one of the big obstacles is the how-to of doing it. How do we actually do this? And what are the practical steps of doing it? And I think where there has been technical guidance on migration data, there hasn't been health-related focus. And where there has been focus on capturing or enhancing health-related data on populations, there has been a very limited guidance, toolkits and playbooks around migration health data. So this is what the primer seeks to do, is to really support technical cooperation processes on how to advance. It's the how-to. So the primer is really a toolkit that it's called the IOM primer, but it's really a universal one. It can be calibrated as a compass to guide countries, sub-regional levels, sub-national levels even, advanced migration health data collection. That's the rationale of the primer. It really seeks to address this gap in technical cooperation in advancing migration health data. The kind of audience for this primer, it's written in a very digestible, accessible way. So it's not just for health system administrators or, health folk. It is for everyone who is interested in advancing a technical cooperation process. Now, of course, it is not an exhaustive primer that lists all of the technical steps to do data linkage, for example, and to do privacy preserving linkages, etc. No, it touches upon these things. It really is the how-to of setting up process at a country level. It provides the practical terms of reference to start intersectoral migration health data coordination team at the national level and the subnational level. It's really about the diplomacy side of things as well as the technical side of things. And so the primer is really seeking to support anyone interested, really, any organization, mission, regional entity, sub-regional entity, researcher or unit, etc., advanced migration health data. So that's the general audience.
How do you think this toolkit can enhance technical cooperation on migration health data?
How the primer can enhance technical cooperation is the fact that migration health data exists at a country level, but it exists in disparate, discrete pools. And it's sort of a patchwork quilt. So you have data, for example, within a vertical control program, like a national TB control program. You can have data sitting in a immigration detention center related information management system. At a border health point, there could be data. The embassy or mission abroad can have data of death analysis or of a foreign national of that country. There could be data from the Foreign Employment Bureau of a country that, has a large out-migration of labor migrants, and they could have health insurance data, right, showcasing the deaths, disabilities, insurance payouts, essentially, of migrant workers. So that rests within repositories at insurance providers or, foreign employment bureaus, for example. There could be data at a cross-border malaria control program interested in malaria elimination. The point I'm trying to make is that data exists already at a country level in various different aspects. It's sort of a patchwork quilt. And one of the challenges is how do we make better use of this available data? It's extraordinary when you start to do these technical cooperation processes at a country level, and the primer does highlight this. Many country examples are highlighted. And one of the biggest lessons learned is there's already already existing mosaic. And one of the challenges is to really map the sources of migration health data. To do so, you firstly need an intersectoral approach, right? So, advancing migration health and health in migration is a intersectoral affair. It is a process that requires the requisite ministries of health, labor, immigration, foreign employment, etc., etc. Multiple ministries need to be involved in this process. But there's also data, bespoke data, especially in context of crisis displacement within humanitarian systems. We talk in the primer about the patient health record systems, EPHR systems, for example. There's data also within health information systems and migration management systems beyond administrative and routine sources of data. There's also survey data. There's things like demographic health surveys and, mixed surveys and labor force surveys. And so there's many opportunities when you map the sources of data to actually have entry points to add the migration module so that you have that disaggregation, right? But I think the first step really is the political will and the diplomatic will and the coordination will. So in the primer, we make emphasis of starting a technical cooperation process. Now, of course, you don't need to do this in a stepwise manner, as we've articulated in the primer. In fact, it's an iterative primer. You can really have multiple entry points, yeah? But the idea is that there needs to be an intersectoral level action. And once you have that, then you can platform the kind of mapping exercises on migration health data. So mapping the sources. Once you map the sources, you can have then the idea of how can we enhance migration health data through the inclusion of migration modules. And what those modules are. Is it the country of birth, country of origin, the place of parents, etc. And we go through the variables that are consistent with international technical guidance on the collection of migration data. But the real premise here is how do we make better use of available data? How can we be resource conserving and preserving given the current climate of limited resources as well in advancing such technical cooperations? How do we integrate migration modules? So really, I think one of the biggest lessons learned in doing this on a practical level, at the country level, at the sub-regional level, is that it doesn't require huge amounts of resources, but lots of coordination and the technical will to do things. And really member states, there's examples from Nepal that have introduced health information systems for labor migrants. And we go through those examples as a way to showcase what can be achieved with relatively limited investment, but for huge outcomes in terms of migration health data. What's really interesting is member states, there is actually a clarion call for better data. The African Union has a specific goal on this. There's sub-regional fora, for example, the Migration Dialogue for Southern Africa, the MITSA, as part of SADC, where there is a clear call for strengthening migration health data at a national level. So the primer really provides the opportunity now to not just enhance data within routine health information systems, but also within migration governance systems. You will find, we hope, a primer that could be applied to whatever technical cooperation process at a country level that you might be in, or what the phase of that cooperation is, and it's sensitive to the kind of capacities that you may have or not have.
Thank you very much, Tamsin and Dr. Kol, and thank you everyone for listening. Thank you for your support in all 18 episodes of the Migration Health Research Podcast. We truly appreciate it. Cheers!